Interventions, TAVI. He has presented various papers, be it national or international conferences, chaired multiple national and international conferences, been investigator to various pivotal clinical trials, and he has been a certified trainer. He has presented various papers, be it national or international CT conferences. I welcome you, sir, and look forward for valuable insights from your end to various pivotal clinical trials. And please join me in also certified trainer in various papers, national or international CT conferences, cardiology research, CMI hospitals, Bangalore, valuable insights from your end to various MCS program in clinical trials of hospitals in Bangalore. Join me in prior to this, he presented various papers, national or cardiology conferences, cardiology research, CMI hospitals, Bangalore, valuable insights from your end to various MCS program in clinical trials of hospitals in Bangalore. Join me in prior to this, he presented various papers, national or cardiology conferences, cardiology research, CMI hospitals, valuable insights from your areas of various program in clinical trials, hospitals in Bangalore. Join me prior to this, he presented various papers, national or cardiology conferences, cardiology research, CMI hospitals, valuable insights from your areas of various program in clinical trials, hospitals in Bangalore. Join me prior to this, he presented various papers, national or cardiology conferences, cardiology research,
Thank you. Good evening, organizers, my eminent co-faculty. First of all, we should congratulate the company for choosing a very vital topic, that is RAS blockers in acute MI. And we are going to talk about what are the important clinical trials which supported one molecule or other. And as an introductory slide, I would like to show you. Each of you know about these RAS inhibitors. They include AC inhibitors and ARBs, and of course we have got ARNI now, which is of very important molecule in the treatment of heart failure, irrespective of its ejection fraction. So with this background, I would like to give an overview of the topic. As you know, all acute MI eyes are inherently going for LV dysfunction and heart failure in majority of them. This is irrespective of the revascularization, and the aim of various molecules is to reduce the deaths, reduce the reinfarctions, and reduce worsening heart failure. That is the main aim of various molecules, and the main culprit is left ventricular remodeling and left ventricular hypertrophy. That, in fact, is the initial step which leads to all these clinical events. So let us see the age-old AC inhibitors, how they have performed. As early as 1987 and early 90s, there are three important trials: SAVE trial, AIR trial, TRACE trial, which as students we had to face the examiners and answer these questions. And they were landmark trials. For example, SAVE is a trial on captopril, which has shown for the first time mortality benefit, not only in acute follow-up, but long-term follow-up. All the three trials are having long-term follow-up. In fact, A trial has extended long-term follow-up, and they have uniformly shown that not only the left ventricular echo parameters have improved marginally, but clinical events have reduced by way of reduced mortality. And SAVE trial, as I already told, has studied captopril maximum 50 milligram TID. So this is a dose even our experienced cardiologist might not have used. 50 milligram TID, 25 BD and 50 BD is the usual dose, but this is the dose they have used, and they compared with placebo, which has shown that there is 19% reduction in the mortality and 25 reduction in the recurrent MI. The echo parameters of cavity size also reduced in this 1992 trial. It is followed by an year later by AIR trial, which was again a large trial, very landmark trial, which has distinctly shown that there is 27% reduction in the mortality, 19% reduction in the rate of MI and strokes at 6 months. Then extension trial has shown that at 5 years, those beneficial effects have persisted despite discontinuing the medicine after 1 year. And TRACE trial has studied tandolapril. For unknown reasons, it's not very popular in clinical practice with us, but these are the important three trials. Then ARBs, among the ARBs, losartan was the earlier molecule which was extensively tried in optimal trial, followed by valsartan trial, which has studied in violent trial. But surprisingly, unlike AC inhibitors, the two ARBs have not shown any significant benefit compared to the placebo. So this was a negative aspect about ARBs with respect to various clinical events after acute MI. This is the details about optimal trial. You can see that both the curves are not much deviating, and so losartan has not become popular in post-MI situation. So also valsartan also surprisingly has not shown any additional benefit in the three arms. One arm was captopril, another arm was valsartan itself, another was valsartan with captopril, and it did not show any difference between various arms. So this was a surprise finding, and so for many years, even valsartan was out of favor for many years. Then let me interact with my panelists. Dr. Ashutosh, can you comment basing on these data? What is your preferred RAS blocker in ACS, whether revascularization has been done or not done? Dr. Ashutosh, are you able to join us? Otherwise, may I request Dr. Pramod Kumar to comment?
Yeah. Thank you. See, we have been using RAS blockers and ACS for quite a long time. And, from very beginning, I've been using Ramipur because, in the early 90s, the trials have clearly established that Ramipur has been a significant edge. And whenever we consider a medicine drug for secondary prevention, definitely we should try to give the maximum benefit for the patient. So among the AC blockers, definitely Iramipur has got much more data, and also with if you consider HOPE trial, which you didn't mention, that's also one of the very important trials which showed significant benefits. So usually I prefer Iramipur always.
Thank you, sir. Did you find any challenges with respect to the dose? Many times we see that in the clinic, we come up to 5 milligram twice and discharge the patient. And during follow-up, is managed by his own physician or some RMPs, and those your BP is now very low. Let us reduce the dose like that. Do you feel such challenges are there?
Yeah, definitely some people may reduce, but in my practice, I always try to give go up to 10 milligram of
Yeah,
that has
as long
been
as they are
from
under
very
our
beginning.
care, we do the recommended doses, but it is a common practice even in advanced cities and centers. Within 3 to 6 months, the dose gets reduced during the follow-up.
I do.
What is the experience of other panelists, Dr. Suresh, Nagamalesh?
We wanted to increase the dose of our ACE inhibitor. Then once the general practitioner sees a BP of around 90 or 100, even though the patient is not symptomatic, they try to reduce the medication. And the benefit of the ACE is lost when in post-myocardial infarction patients. Many times physicians always assist when they see the blood pressure of around 100 or even 90 to 100, but no symptoms. The patients who are stable on Ramipur, they try to reduce some dose of Ramipur.
Yeah, this is an important challenge, right? Yeah, will you switch to ACE inhibitors if somebody is there post-MI case but receiving ARB for his hypertension previously? Dr. Pramod?
Yeah, definitely. See, if you want to give the maximum benefit for the patient, the ARB post-MI doesn't have much data at all. So I always try to switch to Ramipur, starting with 1.25 milligram dose and going up to the maximum dose. Unless the patient has got some previous history of AC intolerance, then only I don't consider stopping the ARB.
Thank you, sir.
I think that's
Yeah, that should be the practice actually, because the AC inhibitors are proven to be of benefit in large 3 trials, as we have shown, and ARBs had doubtful benefit. They are only slightly safer with respect to cough as a side effect. Tolerance may be slightly better. For hypertension, is still okay, but when it is LV dysfunction, especially post-MI situation, I think we should switch back to AC inhibitors. Thank you. Coming to ARNI. ARNI is coming in a big way, and everybody knows. With respect to preserved ejection fraction also, it has some positive findings in various trials, but in the setting of post-MI, did we achieve any additional benefit over well-established AC inhibitors or not? This has been the main aim of Paradigm MI trial. This is a large trial. This was extensively discussed in ACC 21 and onwards. And these are the inclusion criteria. One arm is the ARNI with 200 milligram twice, about 3,000 patients, and Ramipril 5 milligram twice in about similar number of patients. And they looked for CV deaths, heart failure, hospitalization, and OPD development of heart failure. These are the primary, and India has also participated actively in this. And the clinical profile of both the arms were somewhat similar with respect to all the various parameters. And the primary outcome results have surprisingly not shown any additional benefit of sacubitril valsartan over ramipril. The curves were in fact much more positive towards the ramipril, and so it is p-value is only 0.17. With respect to mi also, the curves did not diverge much, and the p-value was only 0.16. So the summary of the findings in Paradise MI was sacubitril valsartan did not result any significantly lower CV deaths or heart failure hospitalization or outpatient heart failure requirement treatment. And both the investigator reports of primary composite and total adjusted events support some incremental beneficial value of sacubitril valsartan. And of course, the safety and tolerability of sacubitril valsartan in post-MI was comparable with SC inhibitors. So this is one silver lining in the study, that ARBs were not distinctly harmful, but they didn't show any additional benefit or distinctly different benefit with compared to ramipril. So in the following this ACC 21, there are a number of publications and criticisms from editorials, like very funny titles you can see. Paradise MI, sacubitril valsartan cannot beat ramipril in acute MI. Paradise MI, ARNI did not surpass SE inhibitors after acute MI. Paradise MI makes me question the benefits of sacubitril valsartan. So such comments came in widely, and this was a discussion point in various conferences and opinion leaders. Now I request our panel members to comment on, based on the primary outcome results, do you think ARNI we should consider? Do you think it is not has enough strength to be recommended in post-MI situation? Sir, Dr. Pramod, sir.
Definitely, army is not the choice at all for post-MI patients, because we don't have any significant data at all. But when you consider AC blockers, we have significantly very good data to say that that is beneficial. So I don't think that by any chance we should consider army as a choice at all. But in patients whom AC is intolerant, then definitely we can consider army.
Thank you, sir. Dr. Nagamalesh, sir.
Sir, Nagmali sir is not joined. Sorry, suddenly there was an emergency.
Okay.
We can go ahead with the next panel, sir.
Right.
Ashutosh and Dr. Suresh Davis can.
Dr. Ashutosh, Dr. Suresh, can you please comment?
Good evening, everybody. I think so far, whatever the studies has been done in the previously regarding the heart failure, it was for the dilated cardiomyopathy, and which we are not knowing what exactly is the previous background. It was generalized that patients with heart failure were having benefit over the enalapril, but we are having very little data regarding the ramipril comparison. And as post-MI is a totally a different entity, where we were expecting that maybe ARNI may be equivalent or maybe better, but it has failed. So every heart failure or every clinical subset should be seen in that background, and accordingly we should treat. So far, we are having evidence that ramipril is a good drug in favor of post-MI remodeling, as well as in the acute condition. So my take is for patients who are having clear-cut heart failure, over the enalapril, the ARNI is doing very good. But when it comes for the acute MI setting, where already the established drug, we are still lacking the evidence in favor of heart failure or in the acute management of post-MI circumstance. So ramipril is still the best choice, and it should be done.
Is there any explanation about this mechanism of why ischemic subset of heart failure may not be similar to non-ischemic heart failure subset? Why ARNI has failed here?
So,
is there any explanation? Any one of you, sir?
We are not having I think we are not having a sound foundation for why drug has worked in this one. But if you see from the first study of paradigm trial, it has scored over the enalapril only. And
Yeah.
as we know, enalapril is not a very good it is a good antihypertensive, not a very good heart failure drug. So when it comes to the heart failure, we have scored, no doubt, but in the background of the what we call patient's profile, it is only the heart failure. It is not the ischemic driving the heart failure which is going to be beneficial. So that will be one of the creator works in the parameter starting modeling to the ischemic distance and the analog. So certainly this may be the one of the reason why over the enalapril in the heart failure it has worked, but not on the it is my take.
Yeah, thank you. I think one of the experts I had talking in a lecture, he says that the neurohumoral adopting mechanisms have not matured in post-MI situation, like chronic heart failure. Probably that's why ARNI is not so much effective. That's what he said. But I think there are several views on that. This is not the forum to discuss so many details about ARNI now. Okay, let us go to the. Now, what are the various current guidelines suggesting, basing on these evidence? The latest ESC guidelines 2017 post-MI guidelines on ACE inhibitors were, it is class 1 with level of evidence was A. Then ARB is also post-MI, if there is ejection fraction less than 40%, early heart failure, diabetic and heart failure, hypertensive patients, there it is, recommendation is class 1 with evidence is level of B. And for all the STEMI, with respect of ejection fraction, within for 24 hours, there are 2A recommendations. So these are various ways of giving the strength of recommendation. And in 2023, ESC has given its guidelines on acute coronary syndromes. There you can clearly see that ACE inhibitors are recommended in ACS patients if there are heart failure symptoms and if there is ejection fraction is less than 40%, diabetic subsets, hypertensive subsets, or CKD. So it is a class 1 recommendation in CKD patients as well as ACS patients with heart failure symptoms, and especially if the ejection fraction is less than 40%. It is similar recommendations are also given for MRAs as class 1 recommendation and beta blockers, of course. So now there is upgradation of the recommendation to class 1 in wide variety of patients, that is diabetics, hypertensives, and CKD, and if the ejection fraction is less than 40%. So in post-MI, there is a state-of-art review, time-dependent therapies in post-MI heart failure. It has clearly shown that within the first 24 hours, it is important and very useful if you are able to introduce ACE inhibitors. There is 40% survival benefit from ACE inhibitors from day 1 itself. And after 24 hours, probably you can introduce aldosterone antagonists, which is again time dependent, and within first 7 days better be given. But unlike the initial thought process, that is giving beta blockers in first 24 hours, it is better be given after the decongestion is perfect, the patient is dry, then start the beta blockers in a low dose and gradually increase. So the essence of telling this is that ACE inhibitors can be given even before first 24 hours. Beta blockers, you can wait to the later phase of 24 hours or early phase of second day and gradually think a right time to use it. And before discharge, they should be, of course, evaluate and stabilize the initial 2 or 3 molecules, that is AC inhibitors, beta blockers, and aldosterone antagonists. This is the recommendation in the review in 2018. After the 2018, of course, now SGLT2 inhibitors are also getting very important place, and they are recommended in the early phases of post-MI. So I will ask my experts, is there a timeline or is there a sequence in which these 4 important drugs have to be given? Vijay Kumar, Pramod sir, what is your practice like? Is there a sequence? Do you follow sequence, or how do you do it actually? Dr. Astosh? Okay, there seems to be some.
No. So you just got disconnected, sir. Sir, Suresh sir can share in the meanwhile.
Yeah. Suresh sir,
Just got disconnected.
how do you introduce these important 3 molecules, beta blockers, AC inhibitors, and of course MRAs after post-MI?
But many times we're forced not to use it because many of the patients come with heart failure, and when you give diuretics, it may produce hypovolemia. That is one period. There is a hesitancy in starting ACE inhibitors. If it's a stable heart coronary disease, when post MI, LVF is less than 40%, but patient is not has not received significant diuretics, then ACE inhibitor I will start. But in a patient of hypovolemia, I will take a while for things to settle after the diuretic dosage and then start ACE inhibitors as first choice. Then we may add beta blockers and the aldosterone antagonists. And SGLT inhibitors, we are starting right away because I don't think there is any time gap for starting an SGLT inhibitor.
Yeah, I think the practice is almost similar to what we do. We have to see the clinical condition of the patient, his stability, whether is there ongoing angina, is the systolic blood pressure is stable, is potassium level is acceptable. All these things are to be taken into consideration, and then we do start AC inhibitors wherever it is feasible. Like there can be 2 subset of patients. One, they're very well stabilized by end of the first day. There can be a subset where still heart failure symptoms are still there. So we have to assess, we have to see the decongestive status and then introduce ARNI. Yeah. So in post-MI, post-revascularization, suppose there is primary PCI done in acute MI, what do you want to do? Do you want to start beta blockers first or AC inhibitors, or is it different if no revascularization is done? Dr. Suresh?
You can change whether you vascular or revascularize as far as treatment is concerned. We'll start with ACE inhibitors and then followed by beta blockers. But if some patient has significant tachycardia, then you may start a beta blocker if the patient is not in heart failure. You would like to control the heart rate. And definitely beta blocker in post-MI situation is known to reduce ventricular arrhythmias. So that is one area where you favor a beta blocker if the patient is not having any failure symptoms.
Yeah.
Acute failure, I mean.
What is the usual choice of your beta blocker in post-MI situation?
You use the 3 cardiac selective beta blockers. So you can use bisoprolol, which is now getting favorable these days. You can start a very low dose of 1.25 and start escalating. Or you can use the good old carvedilol. The only thing is that you have to be a little careful about the blood pressures when you start carvedilol. And one which one is commonly used is metoprolol, but now we are looking towards more of bisoprolol than metoprolol these days.
Thank you. I think for the students and the junior consultants, we should not be in a too hurry. At the same time, we should not unnecessarily delay the introduction of very important molecule, that is beta blockers, AC inhibitors, and MRAs in a post-MI situation. Now there is evidence to start SGLT2 inhibitors as early as possible, because we don't have, there is need not be titrated as accurately as AC inhibitors or beta blockers with respect to SGLT2 inhibitors, and they are found to be useful irrespective of the etiology of heart failure and irrespective of the diabetic status. So one should be one should concentrate on these 4 molecules, and definitely, if not in the first day in ICCU, when you transfer the patient from ICCU to a cool ward, that is the time to introduce most of these evidence-based medications one by one. So, is ramipril different from various SE inhibitors? Is there any different, or is it a class effect? This has been a question, and there is some old trial in 2004. They have compared these molecules, and what they found is that ramipril has the best molecule as compared to all other SE inhibitors with respect to mortality reduction. You see, in this particular trial, which involved large number of patients, ramipril has reduced the mortality to the best extent compared to captopril or fosinopril or enalapril, lisinopril, and all these things. So among various SE inhibitors, ramipril seems to be the best choice. Then these are the questions we have already discussed, like, will you put the patient on AC inhibitor or ARNI in a post-revascularization status if there is LV dysfunction less than 40%, but there is no clinical heart failure? So whether there is clinical heart failure or not, it is, if the ejection fraction is less than 40%, it is enough evidence to start AC inhibitors. So you don't have to withhold AC inhibitors if there is no clinical heart failure. In what scenario will you directly advise ARNI? What dose do you use? So this question, I think ARNI is not yet been proven to be used in that way, even if there is no clinical heart failure in post-MI situation, though revascularization has been done. So this is the answer for it. Then this is the another important question regarding these molecules. What is the incidence of cough in Paradise MI? The reported adverse events with respect to ramipril was 13% compared to 9.1% in ARNI, and cough as a reason to discontinue was around 2.3% in ramipril and 1.2% in ARNI. So cough is maybe a limitation factor in some of the patients. What do you feel, Dr. Suresh? In your practice, do you think it is an important factor for not using ramipril?
Start on ramipril, but not every patient. Few patients definitely complain of severe cough.
Yeah.
That is time when you change over to ARB. That is the one only. I think it's the only indication we are changing from ACE to ARB is when the patient has got a very difficult to tolerate the cough. Some people do have feel cough.
Yeah, in my practice also, because AC inhibitors are so they are proven beyond doubt that they are very beneficial. We try to continue the AC inhibitors for 1 more day or 2 more days so that the cough may self-limit, or you give some low dose of antihistaminic syrup or tablets and reassure the patient. Probably by continuing ramipril is much better than stopping and giving ARVs, because we have seen that ARVs have not proven to have extra benefit as much as AC inhibitors. So the take-home messages from our discussion today is, In post-MI patients with LV dysfunction, SE inhibitors are consistently have shown to reduce hard points, that is CV deaths and all-cause mortality, as proven in SAVE trial, A trial, TRACE trial, ISIS-4, GC3. But in this scenario, SE inhibitor seems to have a class effect, but in elderly patients especially, ramipril seems to be a choice molecule among the various SE inhibitors. In Paradise MI trial, this is the first and only clinical trial so far with ARNI compared to ramipril. It did not outperform ramipril with respect to cardiac events. So ramipril 10 milligram per day, that is 5 milligram twice, offers maximum benefits as proven in 8 trial and Paradise MI. We should give maximum benefit to maximum patients, and cough as a side effect is not limitation in many of them. If you have other useful options. So with this, I'm stopping to share the PPT. If there are any other points we can discuss.
Yes, sir.
Yeah.
Thank you so much, sir. There are a few queries which has come, sir, directly as messages, sir. So there is a query stating that for adults who have been found to be diabetic and hypertensive and having microalbuminuria, for as a primary prevention, which RAS blocker would you recommend, ACE inhibitor or ARB?
No, actually, if it is post-MI situation with diabetic hypertension, SE inhibitors are the drugs. There is some trials which suggest that ARBs may reduce the proteinuria better, but if you take the overall CV events, mortality benefit, SE inhibitors cannot be avoided in this subset.
What about for primary prevention, sir? Because now we see younger adults also in India getting diabetes and obviously having hypertension. So for that subset, should we consider ARB or ACE inhibitor, sir?
Yeah, ARBs, I think, are best for simple hypertension without any target or organ damage. If there is diabetes, if there is CKD, if there is LV dysfunction, then SE inhibitors score over ARBs. If the cough is intolerant, there, of course, we have no option but to go for ARBs. Yeah.
Okay, sir. And as you mentioned about cough, sir, and there was one question that how much cough, I mean, what is the incidence of cough? Okay, that is written. Incidence of cough in your practice, and
Yeah, I
do you
will
recommend
ask
this to be a fear
Astosh
and
to comment on this. Astosh, can you comment on cough as an limitation for the use of?
It is I think important factor when we have to convince the patient that the benefit of the drug scores over the cough, and this cough is mostly self-limiting. And in my practice, usually whenever I start either this one or sometime perindopril in some of the condition, some of the hypertensive patient, I clearly say you may have cough for 5 to 7 days, bear it, but the benefit of this drug is far better than the previous medicine if at all you have tolerated well, but the benefits was not from the pleiotropic effect point of view. So in that situation, we can say 5 to 10% patient, whatever they are saying that it is 25%, 30%, and when any new drug comes, they always show the advantage. But one point I want to add here, that cough is good for the patient. In one of the study, it has been shown that the patient who is having heart failure and given the ramipril, the chances of developing pneumonia was less. And the reason it has been shown, the background it means which has been studied, that when the patient has been given the ramipril, the cough was one of the protective reflex which has initiated the what you call infection, which in which the bacteria goes inside and settle down. The chances is less. The reflexes was very strong, and even the ramipril was the receptor which was blocking the pneumococcal bacteria infection in the initial stages. So it is a protective reflex, and at the same time, it reduces the incidence of pneumonia also, that we have to keep in the mind, particularly in the heart failure patient or patient who is having comorbidity, for which we give the pneumococcal vaccines to prevent the pneumonia. So that is one thing. And regarding the uh, cough, yes, if we are giving time, most of the patient tolerate. Only 5 to 10% patient, we can say that they are so much cough that they say that, sir, you should give me other choices. In my practice, not more than 5 to 10% patients.
Yeah, in real fussy patients, we have got several placebo-like medicines like tulsi syrup
Yeah.
and other things. That Suresh, you have any comment on cough for AC inhibitor?
Cardiologist will, hope I'm audible.
Yes, sir.
The problem is not with the cardiologist. Actually, the cardiologist would love to continue with the ACE inhibitor. But the problem is that these people always go to the physician, and the first thing the physician will say, it is your drug which has caused this.
Yeah, correct.
Yeah.
So then we are in a big problem. They will say, sir, this is the complication of this drug. That is the first thing the physician or the PGP was referred to, the patient will say. Then you have no choice to change from an ACE inhibitor to an ARB for the sake of the doctor who was referred. Because it's something is very common. They feel it is a big defect of the ACE inhibitor, the cough. They don't, like what we said, they don't tolerate the cough. They are not ready to talk to the patient, but they say it's a side effect. And that is how we end up going for an ARB or ACE. That's what I feel. Not a cardiologist, but we are forced to put an ARB. That's the problem.
True, sir. So also, one point is like we hear a lot from the physicians that they have been told that ARBs are nothing but ACE inhibitors without cough. So is the
Yeah.
statement justified? Are you
No.
getting all the benefits of ACE inhibitors without cough by giving ARBs?
Oversimplified and misleading statement. Yeah.
Yes.
Truly a misleading statement it will
Yes.
be. And
So one of the I just want one point I add to ARBs are no doubt one of the most tolerated drugs, and that is one of the premises on which it runs, because it doesn't give any pedal edema like calcium channel blockers, and it doesn't give cough. But at the same time, it is not that effective when it comes to the heart failure management and post-MI conditions. It may be a good antihypertensive, it may work on the hypertension, but when it comes to the remodeling point of view, and what you call pleiotropic effect point of view, it doesn't come near to the ACE inhibitor, particularly with the ranking. This
okay,
point, it is very important to understand for every person who just equate the antihypertensive effect with the ARBs. ARBs having good antihypertensive effect that ramipril may not be having, but the remodeling effect, the pleiotropic effect, it works on the endothelium, is far ahead of, or it can't be equated with the ARBs.
ARBs. So perhaps that's the reason why the AIR trial, which is even though old, still people refer to the AIR trial, and the on target or the transcend, which were done, probably they could not match in terms of benefits. So also there is in a forum, there was a discussion earlier that giving a combination of ramipril or ACE inhibitor for that matter, in combination with calcium channel blockers, will it limit cough, sir? Is there any kind of a data to substantiate this?
No, I'm
Giving
not aware.
calcium blocker
I'm not
because
aware of that type of trial.
nothing of that sort. Sir, in post-MI space, there is a question. Post-MI space, ramipril and or ACE inhibitors, beta blockers are generally given. So, is it possible that a combination therapy can also be given if available?
See, combination therapy has the advantage of better compliance and less cost to the patient. But post-MI situation, when the patient is still not stabilized, we don't know which component has to be up titrated or down titrated. So that's not the ideal. Suppose somebody post-MI 6 months stabilized, then you may think of some combination pills so that the compliance or secondary prevention can be better taken.
Okay, sir. Okay, sir. Right, sir. These were the questions. I think more or less the questions which I am seeing are answered, sir.
We have broad-based discussion. I
Yeah,
think
sir. Yes, sir.
Dr. Anup has to be congratulated for coordinating and his whole team for making this platform for every one of us. It was very useful discussing. And
Sir, if you allow one last question, sir, there is a
Yeah.
question. So Arni in Paradise MI, we have seen. So will Arni, okay, the question is, should all ACE inhibitors patient should be given Arni at the beginning because future is more about Arni. So what is your advice?
Post MI, we are not it's not indicated. It's not on level indication. If somebody is giving, then at their own risk.
At their own risk. So it is, I mean, even now also, even in 2024, we can safely say that ACE inhibitors should be given for post-MI patients.
Only in animal studies, it has been proven to be slightly beneficial. But this is the first and only large trial on human beings, which has not given, unfortunately, it has not given an edge to RNA over AC inhibitors.
Okay, sir. For beta blocker, there is a question on which day after a revascularization procedure will the experts start beta blockers and what dose they initiate?
Beta blockers should be given if there are no contraindications the moment the patient is come for your first checkup. And luckily, those who are practicing in bigger cities, even the peripheral centers, they are already starting it. So fortunately, it's a good thing they are doing. Like metoprolol is such a commonly used drug, and they are already on metoprolol extended release 25, most of them. Only they are a little hesitant about starting carvedilol, bisoprolol, or other proven drugs. So I feel if there is heart failure, there's 4 drugs. One of the 4 drugs can be given: metoprolol extended release, or bisoprolol, or carvedilol, or in elderly maybe nebivolol. And it should be given as early as possible. Maximum tolerated doses. All the GDMT drugs, for that matter, should be given as close to the dose used in the trials, so that the maximum benefits can be obtained. So there are 2 things. One is target dose, one is maximum tolerated dose. So in clinical practice, you have to see what is the target dose in the trial which has proven, what is the maximum tolerated dose in the particular index patient you are treating. Then you have to go stepwise. And earlier you reach closer to the target dose, not only with respect to beta blockers, AC inhibitors, even for RNA in non-post-MI situations, one should try to reach the dose which is recommended in the trials. Of course, there are some factors like female sex may not, female gender may not tolerate maximum doses, small framed, frailty, all these things. Some people have inherently low BPs. Some people may not tolerate, and you have to individualize how fast you will do the up titration. Yeah.
So
Can I add one point?
Yes,
Can
sir,
I
please.
add one
Yeah.
point?
Yeah,
So
sure.
in revascularization, we are having 2 set of patients. So one patient who are coming very late and who are in the cardiogenic shock or pulmonary edema. This type of patient, usually 24 to 48 hours, the minimum time we should wait even after revascularization. But if a patient who is presenting very early and particularly who are anterior wall MI, where the tachycardia is ongoing, immediately, even as per the trials, we can give before taking the patient the cath lab also. It will reduce the ischemia burden and as well as the pain also. In 25 milligram QID and 50 milligram QID was the metoprolol tartrate form, not succinate. So which come as a beta lock plane, which is the preparation. Or if the patient is post MI and anterior MI, we have thrombolized or we are giving. In that situation, when the tachycardia, when the heart rate is more than 100 or at least 90 plus, we can safely start, provided the blood pressure is not below 100/70 or the patient is not in the hypotensive stage. So this is for inferior and right ventricular infarct. Inferior usually it is with the bradycardia, so most of the time we are not giving. But right ventricular infarct, where the tachycardia is one of the response in which the patient may be having tachycardia as a reflex form, there we have to avoid it. Even the patient is having inferior plus right ventricular infarct and tachycardia is ongoing, we should not be hurried to start the beta blocker. We have to give the fluid overload, revascularize, and at least 24 to 48 hours we should wait before starting. So pulmonary edema, patient presenting late, and finally the patients who is having inferior and right ventricular infarct should take at least 24 to 48 hours before hemodynamic is totally stable. Then only we should start. Anterior MI, if they are not in the pulmonary edema, we can start early.
Thank you. It's a very
Thank you, sir.
good educational points you have given. Thank you.
Thank you,
Sir,
sir.
one remark from all the experts, because many young PG students are here. Any one point would you like to give, one from each expert, sir?
Sir,
Before
though
we
you cannot able to see here, we have almost pan-India 300 delegates are there, sir, currently. This is live. So, yes, sir.
Right. Actually, the rational way of treatment in post-MI situation is you have to go by the evidence from the trials. So as it stands now, SEV inhibitors are the first choice. Of that, ramipril is the most preferred because lowest mortality with ramipril. So if cough or any other side effect like angioedema or something is not there, probably you have to try that first, up titrate to the at least 5 milligram twice within say 7 days and continue it. That is a take home message from me. Dr. Suresh, you can also give final message before closing this session.
The chronic heart failure treatment, because in our mind there's a chronic heart failure where RNA is superior to ACE, and there are guidelines which say you should change from ACE inhibitors of RNA after 36 hours of stopping the ACE inhibitors. But this is for a total different scenario as we discussed, and this should not be taken into the post MI situation. That is what I would say that should be in all clinical practices. They should keep it in mind, actually. Yeah.
Yeah, Astosh, final.
Yes, sir.
Final comment.
So I want to say that when for all the PGs or who are just pursuing or maybe pursuing after some time coming in the clinical practice, it is very important to keep your all the reflexes, eyes as well as mind open, and be open to challenge whatever has been coming from the studies. Because if you are going in the delicacies or you can intricacies of the trials, there may be always some fallacies in things which has been hidden and something which has been overexposed. So in present scenario, when the RNA is marching in the market, we should not be totally biased. We should go by the study, and most important thing, never ever miss the opportunity what the patient is saying and what patient is doing. If the patient is doing good and the trials is not supporting, you should always think that something is hidden. So one is the trial, which we call as a randomized trial, and second is the real world data. If both are matching, go by it. Most of the things are correct. But if the real world data is not favoring, is not as impactful as the randomized trial, always suspect that it has been overinflated than the value of the trial. So uh, kindly see the patient. US patient or you can European patient and Indian patient, all are different. What has been studied, it was studied in the real world, sorry, in the controlled manner. Whether it is replicating in the same in the clinical practice is an important thing that you have to learn over the time, and it is a test of the time that the drug has to give before we should accept it or reject it.
Very apt message, sir, I think. Thank you so much.
With these excellent comments, I think you can conclude the session.
Right, sir. I think we had a feast today with the scientific discussion from the luminaries over here. And I'm sure that our audiences would have gained a lot of insights, especially for the post-MI patients, with respect to choosing an apt RAS blocker for their patient profile, sir. And with this, I would like to thank all the experts, starting from Dr. Patnaik, sir, Suresh Davis, sir, Dr. Ashutosh Kumar, sir, Dr. Nag Malesh, sir, Dr. Pramod Kumar, sir. So for your valuable time and guidance, and we definitely look forward to again meet in the near future for a similar kind of a scientific activity. Thank you so much, sir, and have a good night.
Thank you.
Thank you, Dr. Thank you, everybody.